Describe the underlying pathophysiological mechanisms of acne vulgaris and how they contribute to the clinical presentation of the condition. Discuss the role of androgens and sebum production, the process of follicular occlusion, and the influence of bacteria. Answer: acne vulgaris is a multifactorial inflammatory disease of the pilosebaceous unit. The primary contributing factors include increased sebum production, follicular hyperkeratinization, inflammation, and the proliferation of Cutibacterium acnes, formerly Propionibacterium acnes. Sebum production and androgens, particularly testosterone and its derivatives, stimulate sebaceous glands to produce excess sebum. Elevated androgen levels, often seen during puberty, lead to enlarged sebaceous glands, increasing sebum production. Follicular occlusion. The normal process of desquamation is disrupted in acne, leading to keratinocyte proliferation and excessive keratin production. This results in follicular occlusion, preventing sebum from exiting the pore, contributing to comedone formation, open and closed comedones, bacterial proliferation, and inflammation. The occluded follicle creates an anaerobic environment conducive to the growth of C. attins, which can trigger an inflammatory response. This inflammation manifests as papules, pustules, and in severe cases, nodules and cysts. Discuss the treatment options for psoriasis, including the rationale for using topical treatments, phototherapy, and systemic therapies. Include indications for each treatment modality and potential side effects. Answer: psoriasis is a chronic inflammatory skin condition characterized by high proliferation of keratinocytes and immune dysregulation. Treatment is individualized based on the severity and extent of the disease. Topical treatments. Indications: first-line therapy for mild to moderate psoriasis. Options: corticosteroids, anti-inflammatory, vitamin D analogues, calcipotriene, and retinoids. Tazarotene are commonly used. These help reduce inflammation and keratinocyte proliferation. Side effects: long-term use of topical corticosteroids may cause skin thinning, tachyphylaxis, and local irritation. Phototherapy. Indications: moderate to severe psoriasis, especially when topical treatments fail. Options: narrowband UVB and PUVA, psoralen plus UVA are effective. Phototherapy targets the high proliferative skin and induces apoptosis in keratinocytes. Side effects: risk of skin cancer with long-term use, and PUVA can cause nausea due to psoralen. Systemic therapies. Indications: severe psoriasis or when the disease significantly affects quality of life. Options: methotrexate, antimetabolite with immunosuppressive effects. Biologics, targeting specific immune pathways like TNF-alpha, IL-12/23, and IL-17, and apremilast, PDE inhibitor are effective. Side effects: methotrexate may cause hepatotoxicity and myelosuppression. Biologics can increase the risk of infections and malignancies. The choice of treatment depends on patient factors, including disease severity, comorbidities, and previous treatment responses. Explain the primary risk factors associated with non-melanoma skin cancers (SC) and their prevention strategies. Discuss the differences in risk for basal cell carcinoma versus squamous cell carcinoma. Answer: non-melanoma skin cancers, primarily basal cell carcinoma (BCC) and squamous cell carcinoma (SCC), share several risk factors but also have distinct differences. Common risk factors for both NSCS: ultraviolet UV radiation exposure. Chronic exposure, particularly from sunlight or tanning beds, is a significant risk factor for both BCC and SCC. Skin type: individuals with fair skin, light hair, and light eyes are increased risk due to low melanin levels, providing less natural protection against UV damage. Age: the risk increases with age as cumulative UV exposure over time affects skin integrity. Specific risk factors: basal cell carcinoma (BCC). It typically occurs in sun-exposed areas. Face, ears, neck, rarely metastasizes but can cause local destruction. High incidence in individuals with a history of prior skin cancers or those with conditions such as Gorlin syndrome. Squamous cell carcinoma (SCC). More aggressive than BCC with a higher risk of metastases. Associated with actinic keratosis, precursor lesions, immunosuppression, and exposure to carcinogens e.g. arsenic, radiation. Prevention strategies: avoidance of UV exposure, use of broad-spectrum sunscreen, protective clothing, and avoiding tanning beds. Regular skin examinations. Early detection through routine skin checks and educating patients about changing moles or skin lesions. Understanding these factors allows for better prevention strategies and timely interventions in at-risk populations. Mr. Smith, a 30-year-old male, presents with erythematous pruritic lesions on his hands that developed after he started using a new cleaning product. What steps should be taken to diagnose and manage his condition? Include any relevant guidelines or recommendations. Answer: Mr. Smith's presentation suggests contact dermatitis, likely irritant or allergic in nature due to exposure to the new cleaning product. Diagnosis: history taking. Obtain a detailed history of exposure, including the specific product used and the onset of symptoms. Assess for any prior skin conditions or similar reactions. Physical examination. Examine the lesions for characteristics typical of contact dermatitis, such as well-defined edges, vesicles, or scaling. Patch testing. If allergic contact dermatitis is suspected, referral for patch testing can help identify specific allergens. Management. Avoidance. Advise Mr. Smith to discontinue use of the offending product and educate him about potential irritants in household products. Topical corticosteroids. Mild to moderate potency topical corticosteroids can be prescribed to reduce inflammation and pruritus. Examples include hydrocortisone or triamcinolone emollients. Recommend regular application of emollients to help restore the skin barrier and prevent dryness. Follow-up and education. Schedule follow-up to assess treatment efficacy and adjust therapy if necessary. Educate Mr. Smith about recognizing triggers and the importance of patch testing for long-term management. Guidelines from the American Academy of Dermatology emphasize avoidance of irritants and the use of topical treatments as first-line management for contact dermatitis. Compare and contrast the clinical features and treatment strategies for herpes simplex virus HSV infections versus human papillomavirus HPV infections in the context of dermatology. Answer: herpes simplex virus HSV and human papillomavirus HPV infections present differently and require distinct management strategies. Clinical features: HSV infections, typically present as group vesicular lesions on an erythematous base, commonly affecting the lips HSE1 or genital area HSE2. Primary infections can cause systemic symptoms like fever, malaise, and lymphadenopathy. Recurrent infections often manifest as localized lesions triggered by stress, illness, or UV exposure. HPV infections. HPV can cause various skin lesions, including common warts, verrucae vulgaris, plantar warts, and genital warts, condylomata acuminata. Lesions are typically hyperkeratotic, raised, and rough in texture. Treatment strategies: HSV. Antiviral medications such as acyclovir, valacyclovir, and famciclovir are used for both acute outbreaks and suppressive therapy to reduce recurrence. Topical antiviral creams may be applied during outbreak. HPV. Treatments focus on lesion removal, including cryotherapy, topical salicylic acid, or surgical excision for warts. Imiquimod, an immune response modifier, can be used for genital warts. Prevention. For HSV, education on safe practices during outbreaks and potential transmission is crucial. HPV has vaccines, Gardasil, Cervarix, that protect against the most common oncogenic strains. Understanding the differences in presentation, treatment, and prevention strategies is vital for effective management in dermatological practice. Discuss the differential diagnosis for urticaria and the approach to determine the underlying cause in a patient with chronic urticaria. Answer: chronic urticaria, defined as hives lasting more than 6 weeks, requires a thorough differential diagnosis due to its multifactorial nature. Differential diagnosis: allergic urticaria, immediate hypersensitivity reactions to allergens, food, drugs, insect stings. Physical urticaria, triggered by physical stimuli such as pressure, delayed pressure urticaria, cold urticaria, or heat urticaria. Chronic spontaneous urticaria occurs without identifiable triggers, often associated with autoimmune disorders. Evaluation. History. A detailed history should include medication use, food intake, and potential exposures. Note the timing and duration of episodes. Physical examination. Assess for signs of associated conditions such as angioedema or dermatographism. Laboratory tests. Consider serum tryptase levels to rule out mast cell disorders and specific IgG tests for potential allergens. Consider screening for autoimmune markers e.g. thyroid antibodies. Management. Antihistamines. Second-generation antihistamines are first-line treatments to relieve symptoms. Omalizumab. For patients not responding to antihistamines, omalizumab, anti-IgG therapy may be considered. Education. Inform patients about potential triggers and the importance of avoidance strategies. A structured approach allows for effective management of chronic urticaria and identification of any underlying causes. A patient presents with a painful erythematous nodule on the lower leg with associated fever and malaise. What is the most likely diagnosis, the causative organism, and the recommended treatment approach? Discuss the underlying pathophysiology and management principles. Answer: the clinical presentation is suggestive of a bacterial skin infection, likely an abscess or furuncle caused by Staphylococcus aureus, often including methicillin-resistant Staphylococcus aureus MRSA. Pathophysiology: Staphylococcus aureus is a common skin commensal that can invade the skin through breaks, leading to localized infection and subsequent inflammatory response. The body responds by recruiting neutrophils, which contribute to the formation of pus and necrotic tissue, resulting in the characteristic painful nodule. Diagnosis: clinical diagnosis is often sufficient, but if there is concern for deeper infection or systemic involvement, an ultrasound or aspiration may be performed to confirm the presence of an abscess. Treatment: incision and drainage. ID: for abscesses, ID is the first-line treatment, allowing for effective pus evacuation. Antibiotics: empiric antibiotic therapy may include oral antibiotics such as trimethoprim sulfamethoxazole or clindamycin, especially if MRSA is suspected. In severe cases or systemic infection, intravenous antibiotics may be necessary. Follow-up: patients should be monitored for signs of improvement and potential complications such as cellulitis or systemic infection. Understanding the underlying pathophysiology and management principles ensures effective treatment and minimizes the risk of recurrence. Explain the pathophysiology in clinical manifestations of Stevens-Johnson syndrome (SJS) and toxic epidermal necrolysis. 10. Discuss the role of drug reactions in these conditions and the importance of early recognition and intervention. Answer: Stevens-Johnson syndrome (SJS) and toxic epidermal necrolysis 10 are severe drug-induced hypersensitivity reactions characterized by extensive skin detachment and mucosal involvement. Pathophysiology: SJS and TEN are believed to be mediated by a complex interaction between drug antigens and the immune system, leading to keratinocyte apoptosis. Cytotoxic T cells target drug-modified antigens on the surface of keratinocytes, resulting in widespread cell death and subsequent skin detachment. The main difference between SJS and TEN is the extent of body surface area affected. SJS involves 30%. Clinical manifestations: prodromal symptoms: patients may present with fever, malaise, and flu-like symptoms before skin changes appear. Cutaneous findings: painful erythematous macules and target-like lesions develop, leading to blister formation and necrosis of the epidermis. Mucosal surfaces, oral, ocular, genital, are often involved. Systemic effects: complications may include infection, fluid loss, and electrolyte imbalances due to extensive skin loss. Early recognition and intervention: prompt identification of the offending drug. Common culprits include sulfonamides, anticonvulsants, and allopurinol is critical. Immediate withdrawal of the suspected drug and supportive care in a burn unit or intensive care setting may be necessary. Systemic corticosteroids and immunotherapy, such as intravenous immunoglobulin, are sometimes used, but the role remains controversial. Understanding the pathophysiology and urgency of intervention can significantly impact patient outcomes in these life-threatening conditions. Differentiate between seborrheic dermatitis and psoriasis in terms of etiology, clinical features, and treatment options. How can you effectively distinguish between the two conditions in a clinical setting? Answer: seborrheic dermatitis and psoriasis are both chronic inflammatory skin disorders but have different etiologies, clinical features, and management strategies. Etiology: seborrheic dermatitis, associated with Malassezia yeast and sebaceous gland activity, often exacerbated by stress, hormonal changes, and environmental factors. Psoriasis, an autoimmune condition with a genetic predisposition characterized by dysregulation of T cell function and keratinocyte proliferation. Clinical features: seborrheic dermatitis. Presence is erythematous patches with greasy yellow scales, commonly found on the scalp, face, especially around the nasolabial folds, and chest. Pruritus may be mild to moderate. Psoriasis. Presence is well defined, erythematous plaques with silvery white scales, often on extensor surfaces, elbows, knees, scalp, and low back. Associated with significant pruritus and may involve nail changes and psoriatic arthritis. Treatment options: seborrheic dermatitis. Treatment includes topical antifungals, ketoconazole, and medicated shampoos containing zinc pyrithione or selenium sulfide. Psoriasis. Treatment options include topical corticosteroids, vitamin D analogs, phototherapy, and systemic therapies, e.g. methotrexate. Biologics. Distinguishing factors: a thorough history and examination can help differentiate the two conditions. Noting the location, scaling, and response to treatments is key. A skin biopsy may be considered for atypical cases. Understanding the differences in etiology, presentation, and treatment is critical for effective management and patient education. Discuss the diagnostic approach and management of tin corporis ringworm versus tinnicapitis scalp ringworm. What are the key differences in treatment strategies and considerations for each condition? Answer. Tinnicorporis and tinnicapitis are dermatophyte infections caused by various fungi, but they have distinct presentations and management strategies. Diagnostic approach. Tinnicorporis diagnosis is often clinical based on the characteristic annular lesion with a raised scaly border and central clearing. KOH potassium hydroxide preparation or fungal culture can confirm the diagnosis. Tinnicapitis presence as patchy alopecia with scaly plaques or Kyrian inflammatory mass. Diagnosis may require KOH preparation of hair or scalp scrapings, culture, or dermoscopy. Management. Tinnicorporis treatment typically involves topical antifungals, e.g. clotrimazole, terbinafine for localized infections. Systemic antifungals, e.g. fluconazole, itraconazole, are reserved for extensive or resistant cases. Tinnicapitis systemic antifungal treatment is necessary due to the deep involvement of the hair follicles. Grisofulvin is a first-line treatment with terbinafine and itraconazole as alternatives. Topical antifungals are less effective for tinnicapitis and are not recommended as sole therapy. Considerations. For tinnicapitis, consider the need for oral treatment, especially in children, and monitor for potential side effects of systemic antifungals. Reinfection and spread of tinnicapitis can occur, necessitating education about hygiene, sharing of personal items, and treatment of close contacts. Understanding these distinctions ensures appropriate diagnosis and effective management of dermatophyte infections. What are the critical components of a comprehensive prenatal care plan, and how do they address potential complications during pregnancy? Answer. A comprehensive prenatal care plan includes several key components aimed at ensuring maternal and fetal health. Initial assessment. A thorough history and physical examination should be conducted during the first visit, including a review of the patient's medical, obstetric, and family history. Laboratory tests, such as blood type, Rh factor, and complete blood count, and screenings for infectious diseases, e.g. syphilis, hepatitis B, HIV, are also performed. Regular monitoring. Follow-up visits should occur every 4 weeks until 28 weeks, every 2 weeks until 36 weeks, and weekly thereafter. These visits involve monitoring vital signs, weight, and fetal heart tones, as well as assessing for signs of complications such as gestational diabetes or preeclampsia. Patient education. Education on nutrition, exercise, and signs of complications, e.g. bleeding, severe headaches, visual changes, is crucial. Patients should also receive counseling on prenatal vitamins, particularly folic acid, to reduce the risk of neural tube defects. Screening for complications. Regular screening for gestational diabetes, typically at 24 to 8 weeks, and preeclampsia, monitoring blood pressure and proteinuria, is essential. Patients at high risk may require earlier and more frequent screenings. Referral to specialists. If complications are identified or if the patient is high risk due to age, medical history, or lifestyle factors, referrals to specialists, e.g. maternal fetal medicine, are necessary to provide additional care and interventions. The American College of Obstetricians and Gynecologists (ACOG) recommends that all pregnant individuals receive individualized care plans that take into account their unique risk factors and preferences. Discuss the management strategies for a patient diagnosed with gestational diabetes. What are the potential risks if gestational diabetes is not adequately managed? Answer. Management of gestational diabetes (GD) focuses on controlling blood glucose levels to minimize risks to both the mother and fetus. Key strategies include dietary modifications. Patients should be counseled to follow a balanced diet with controlled carbohydrate intake, focusing on complex carbohydrates, lean proteins, and healthy fats. Meal planning and education on carbohydrate counting can help maintain stable glucose levels. Physical activity. Regular exercise, as tolerated, is encouraged to enhance insulin sensitivity and aiding glycemic control. Patients should engage in at least 150 minutes of moderate intensity aerobic activity per week unless contraindicated. Blood glucose monitoring. Patients should be instructed on how to monitor their blood glucose levels regularly, e.g. fasting and postprandial readings, to ensure they remain within target ranges. Insulin therapy. If dietary and lifestyle modifications do not achieve adequate glycemic control, insulin therapy may be initiated. Metformin may also be considered in some cases, although it is not FDA approved for GD. Monitoring and follow-up. Regular follow-up visits are critical to monitor both maternal and fetal well-being. Patients should be educated on the signs of potential complications, such as hypertension or macrosomia. Failure to manage gestational diabetes adequately can lead to several risks, including macrosomia, increased risk of large for gestational age infants, leading to complications during delivery such as shoulder dystocia, neonatal hypoglycemia. Infants may experience hypoglycemia shortly after birth due to excessive insulin production in response to maternal hypoglycemia, increased cesarean delivery rates. A higher incidence of cesarean sections may occur due to fetal size or other complications. Long-term risks. Women with gestational diabetes have a higher risk of developing type 2 diabetes later in life, and there is an increased risk of obesity and metabolic syndrome for the child. The ACOG and the American Diabetes Association provide guidelines for the management of gestational diabetes to mitigate these risks. What are the potential complications associated with instrumental delivery, and how should a clinician approach the management of these complications? Answer: instrumental delivery, often performed using forceps or a vacuum extractor, can be associated with several complications for both the mother and the neonate. Maternal complications, perineal trauma. This can include lacerations or episiotomies that may require repair. Severe lacerations, third or fourth degree, can lead to long-term complications such as fecal incontinence or pelvic floor dysfunction. Uterine atony. The use of instruments can increase the risk of uterine atony postpartum, which may lead to hemorrhage. Infection. Instrumental deliveries may increase the risk of infection in the postpartum period. Neonatal complications. Cephalohematoma. This is a collection of blood between the skull and periosteum, which can result from vacuum extraction. Brachial plexus injury. This injury can occur due to excessive pulling on the infant's head during delivery, particularly in cases of shoulder dystocia. Intracranial hemorrhage. This rare but serious complication can arise from the use of instruments, particularly vacuum extraction. Management of complications. Immediate assessment. After an instrumental delivery, immediate neonatal assessment is critical. Any signs of trauma, e.g. cephalohematoma, or neurological compromise should be documented and monitored. Maternal care. Close monitoring of the mother for signs of hemorrhage, infection, or perineal injury is essential. Appropriate repair of any lacerations should be performed, and pain management should be addressed. Education and follow-up. Both the mother and family should be educated about the signs of complications and when to seek medical care after discharge. Documentation of the procedure, including indications for instrumental delivery, the type of instruments used, and any complications encountered, is crucial for legal and clinical purposes. Mrs. Thompson is a 28-year-old woman who had a vaginal delivery of her first child 3 days ago. During a follow-up visit, she expresses feelings of sadness, anxiety, and difficulty sleeping. What steps should her healthcare provider take to address these concerns and assess for postpartum depression, PP? Answer: the healthcare provider should take the following steps to assess and manage Mrs. Thompson's concerns regarding possible postpartum depression. Screening for PPD. Utilize standardized screening tools such as the Edinburgh Postnatal Depression Scale to evaluate the severity of her symptoms. A score of 10 or more may indicate the need for further evaluation and intervention. Comprehensive assessment. Conduct a thorough assessment, including a detailed history of her mood changes, family history of depression, and any psychosocial stressors, e.g. lack of support, financial issues. Inquiry about her support system and coping mechanisms is essential. Education on PPD. Educate Mrs. Thompson about the commonality of postpartum mood disorders, emphasizing that her feelings are valid and that help is available. Discuss the potential impact of untreated PPD on her and her baby's health. Management options. Psychotherapy. If the assessment indicates moderate to severe symptoms, referral to a mental health professional for cognitive behavioral therapy (CBT) or interpersonal therapy is advisable. Pharmacotherapy. For more severe symptoms or if the patient has a history of depression, consideration of pharmacological treatment, e.g. selective serotonin reuptake inhibitors, may be warranted. It's essential to discuss the risks and benefits of medications while breastfeeding. Support services. Encourage participation in support groups for new mothers or community resources that provide peer support and education. Follow-up. Schedule a follow-up appointment within a few weeks to reassess her mood and evaluate the effectiveness of the interventions. Continuous support and monitoring are critical to prevent worsening symptoms. The American Psychiatric Association, APAL, and ACOG provide guidelines for the screening and management of postpartum depression to ensure women receive appropriate care and support. Discuss the differential diagnosis of secondary amenorrhea in a 30-year-old female patient and the necessary workup to determine the underlying cause. Answer: secondary amenorrhea is defined as the absence of menstruation for 3 consecutive cycles or 6 months in women who previously menstruated. The differential diagnosis includes pregnancy. The most common cause of secondary amenorrhea, a pregnancy test urine or serum beta-HCG is essential. Hormonal imbalances, polycystic ovary syndrome, PCOS, characterized by anovulation, hyperandrogenism, and insulin resistance. The detailed history, physical examination, and hormonal assessment serum testosterone, LH, FSH, and insulin levels are necessary. Hypothalamic amenorrhea, often related to stress, significant weight loss, or excessive exercise. A thorough history of lifestyle factors and psychosocial stresses is needed. Thyroid disorders. Both hypothyroidism and hyperthyroidism can disrupt menstrual cycles. Thyroid function tests TSH-3T should be conducted. Hyperprolactinemia. Elevated prolactin levels can cause amenorrhea. Serum prolactin levels should be measured, and if elevated, further evaluation MRI of the pituitary may be necessary. Premature ovarian insufficiency (POI). This condition can occur before age 40. Assessment includes measuring serum FSH and estradiol levels. Structural causes. Uterine anomalies such as Asherman syndrome or polyps can lead to secondary amenorrhea. A transvaginal ultrasound or hysterosalpingography (HCG) may be warranted for imaging. The workup should start with a comprehensive medical history, physical examination, and targeted laboratory tests based on the most likely diagnosis. The ACOG provides guidelines for the evaluation and management of menstrual disorders, ensuring a systematic approach to diagnosis. Evaluate the advantages and disadvantages of long-acting reversible contraception (LARC) methods compared to short-acting methods. Answer: long-acting reversible contraception (LARC) includes intrauterine devices and subdermal implants. In contrast, short-acting methods include oral contraceptive pills, patches, and injections. The evaluation of advantages and disadvantages is as follows. Advantages of LARC. Efficacy. LARC methods have a failure rate of less than 1%, making them among the most effective forms of contraception available. Convenience. Once inserted, LARC requires no daily action, reducing the chances of use or error associated with short-acting methods. Long duration. IUDs can provide protection for 3 years, and implants can last up to 3 years, offering a long-term solution without the need for frequent visits. Disadvantages of LARC. Initial costs. The upfront cost for insertion can be high, although many insurance plans cover these methods. Insertion procedure requires a healthcare provider for insertion, which may involve discomfort or pain during the procedure. Side effects. Some women may experience irregular bleeding or hormonal side effects in the case of hormonal IUDs and implants. Advantages of short-acting methods. Flexibility. Patients can easily start and stop short-acting methods according to their needs, making them suitable for those who may want to conceive in the near future. Less invasive. These methods do not require procedure for initiation, allowing for immediate reversibility. Disadvantages of short-acting methods. High failure rates. They are associated with higher typical use failure rates due to missed doses or improper use. Daily or frequent attention. Require consistent attention, which may lead to non-compliance. Side effects. Hormonal methods can cause side effects like nausea, headaches, or mood changes. Analyze the initial workup for a couple presenting with infertility issues. What guidelines should be followed to ensure a comprehensive evaluation? Answer: the initial workup for infertility in couples generally follows a systematic approach as outlined by the American Society for Reproductive Medicine (ASRM). History and physical examination. A detailed medical history should be taken from both partners, including menstrual history, previous pregnancies, surgical history, and lifestyle factors, e.g., smoking, alcohol use. A physical examination should assess for signs of hormonal imbalances or anatomical abnormalities. Semen analysis. This should be one of the first tests conducted for the male partner, evaluating sperm count, motility, morphology, and overall quality. Ovulation assessment. For the female partner, tracking ovulation is essential. This can be done through menstrual cycle tracking. Regular cycles suggest ovulation, while irregular cycles may indicate issues such as polycystic ovary syndrome, PCOS. Hormonal testing. Serum progesterone levels can confirm ovulation, typically measured on day 21 of the cycle. Assessment of tubal patency. Hysterosalpingography (HCG) or sonohysterography can evaluate whether the fallopian tubes are open and assess the uterine cavity for abnormalities, e.g., fibroids or polyps. Endocrine evaluation, serum hormone levels, FSH, LH, estradiol, and thyroid hormones should be assessed to rule out endocrine disorders affecting fertility. Additional testing, if indicated, further tests such as a karyotype analysis for genetic abnormalities or laparoscopy to evaluate for endometriosis may be warranted. The workup should be tailored to the individual couple, and both partners should be included in the evaluation process to identify any contributing factors to infertility. The ASRM provides guidelines for infertility evaluation and management, emphasizing a holistic approach. Describe the physiological changes that occur during menopause and their potential impact on a woman's health. What management strategies should be employed to alleviate symptoms? Answer. Menopause marks the cessation of menstruation due to decreased ovarian function, typically occurring around the age of 51. Key physiological changes include hormonal changes. There is a significant decline in estrogen and progesterone production, leading to alterations in menstrual cycles and eventually amenorrhea. Vasomotor symptoms. Hot flashes and night sweats are common due to fluctuating hormone levels, often leading to sleep disturbances and mood changes. Vaginal and urinary changes. Reduced estrogen levels can lead to vaginal atrophy, causing dryness, irritation, and increased urinary incontinence or urinary tract infections. Bone health. Decreased estrogen levels are associated with an increased risk of osteoporosis, making women more susceptible to fractures. Cardiovascular health. The decline in estrogen is linked to an increased risk of cardiovascular disease post-menopause. Management strategies. Bone health monitoring. Consider bone density screening for women at risk of osteoporosis and implement preventive strategies such as calcium and vitamin D supplementation. Hormone replacement therapy (HRT). Considered for women with moderate to severe symptoms, HRT can effectively alleviate hot flashes and vaginal atrophy. A thorough risk assessment e.g. history of breast cancer, cardiovascular disease is critical before initiating therapy. Non-hormonal options. SSR is selective serotonin reuptake inhibitors and SNR is serotonin norepinephrine reuptake inhibitors can help manage hot flashes, while vaginal moisturizers and lubricants can relieve vaginal dryness. Lifestyle modifications encourage regular exercise, a balanced diet rich in calcium and vitamin D, smoking cessation, and weight management to promote overall health and reduce cardiovascular risk. Guidelines from the North American Menopause Society (NAMS) provide a framework for the management of menopause-related symptoms and health risks. Evaluate the role of thyroid function in reproductive health and the potential impact of thyroid disorders on fertility. Answer. Thyroid hormones play a crucial role in reproductive health, influencing menstrual cycles, ovulation, and fertility. Key points include hypothyroidism. Low thyroid hormone levels can lead to irregular menstrual cycles. Anovulation may occur, resulting in irregular or absent menstruation. Elevated prolactin levels. Hypothyroidism can cause increased prolactin secretion, further suppressing ovulation. Hyperthyroidism. Excessive thyroid hormone can lead to oligomenorrhea or amenorrhea. Changes in menstrual regularity may occur, with potential anovulation. Increased miscarriage risk. Hyperthyroidism is associated with a higher risk of pregnancy loss and preterm labor. Thyroid function tests. Evaluation of thyroid function (TSH) is essential in the workup of infertility. Normal results warrant further investigation and management. Management. Treatment of thyroid disorders e.g. levothyroxine for hypothyroidism or antithyroid medications for hypothyroidism can restore normal ovulation and improve fertility outcomes. Women planning to conceive should have their thyroid function assessed, as optimal thyroid hormone levels are critical for both fertility and the health of the developing fetus. The American Thyroid Association provides guidelines for the management of thyroid disorders in reproductive health. Discuss the screening guidelines for cervical cancer and the importance of HPV vaccination in reducing cancer incidence. Answer. Screening for cervical cancer is vital for early detection and prevention of invasive disease. Key guidelines include Pap smear. Women should begin cervical cancer screening at age 21, regardless of sexual history. The Pap test should be performed every 3 years until age 29. HPV testing. For women aged 30-65, testing Pap smear plus HPV testing is recommended every 5 years, or a Pap smear alone every 3 years. Postmenopausal screening. Women who have undergone a hysterectomy, removal of the uterus and cervix for non-cancerous reasons do not require screening, although those with a history of cervical cancer should continue to be monitored. Importance of HPV vaccination. The HPV vaccine is a crucial preventive measure against cervical cancer. Vaccination is recommended for preteens ages 11, 12, but can be given up to age 26 and in some cases up to age 45 to protect against the strains of HPV that cause most cervical cancers. Public health impact. Widespread adoption of HPV vaccination and adherence to screening guidelines have the potential to significantly reduce cervical cancer incidence and mortality rates. The CDC and the American College of Obstetricians and Gynecologists (ACOG) provide resources and guidelines to support these initiatives. A 72-year-old male patient with a history of coronary artery disease presents to the emergency department with worsening dyspnea on exertion and lower extremity edema. What initial management strategy should be prioritized in this patient, and what is the rationale behind this approach? Answer: the initial management strategy should be focused on diuresis to alleviate fluid overload. In patients with heart failure, particularly those with congestive heart failure (CHF) due to left ventricular dysfunction, the accumulation of fluid can lead to symptoms such as dyspnea and edema. Administering loop diuretics, such as furosemide, is crucial for reducing volume overload. The rationale for prioritizing diuresis lies in the pathophysiology of heart failure, where impaired cardiac output leads to renal underperfusion and activation of the renin-angiotensin-aldosterone system (ROS). This results in sodium and water retention, exacerbating symptoms. By administering diuretics, one can quickly reduce preload, decrease pulmonary congestion, and improve the patient's respiratory status. Relevant guidelines. The American College of Cardiology American Heart Association (ACOA) guidelines recommend diuretics as first-line treatment for managing volume overload in heart failure patients (ACOA 2017). 55-year-old woman with a 30-pack year smoking history presents with dyspnea on exertion and a chronic productive cough. Pulmonary function tests reveal an FEV ratio of 60%. Discuss the GOLD classification of COPD and the implications for management in this patient. Answer: the Global Initiative for Chronic Obstructive Lung Disease (GOLD) classifies COPD into 4 stages based on the severity of airflow limitation, which is assessed by the FEV. GOLD1: mild COPD equals 80% predicted. GOLD2: moderate COPD 50 equals 80% predicted. GOLD3: severe COPD 30 equals for 50% predicted. GOLD4: very severe COPD FEV 30% predicted. In this patient's case with an FEV ratio of 60%, she is classified as GOLD2 moderate COPD. Management strategies include smoking cessation. The most critical intervention is to stop smoking, which can slow disease progression. Pharmacotherapy, bronchodilators. Long-acting beta-agonists (LOBAs) and long-acting muscarinic antagonists (LOMAs) are recommended for symptom management. Inhaled corticosteroids. These may be added if the patient experiences exacerbations. Pulmonary rehabilitation. This is recommended to improve quality of life and exercise capacity. Vaccination. Annual influenza vaccines and pneumococcal vaccines should be administered to prevent respiratory infections. Regular monitoring. Follow-up visits should focus on assessing symptoms, medication adherence, and adjusting treatment as necessary. This patient requires a multifaceted approach that addresses both symptom relief and prevention of exacerbations. Mr. Rodriguez, a 45-year-old man with newly diagnosed type 2 diabetes, is concerned about the long-term complications of his condition. What educational points should you provide regarding the potential complications of diabetes, and what preventive measures should he take to minimize these risks? Answer: Mr. Rodriguez should be educated about the long-term complications associated with uncontrolled diabetes, including microvascular complications, retinopathy. Regular eye examinations are crucial for early detection. Glycemic control significantly reduces the risk. Nephropathy. Screening for microalbuminuria annually and controlling blood pressure and glucose levels can prevent progression to end-stage renal disease. Neuropathy. Foot care is essential to prevent ulcers and amputations. The patients should inspect their feet daily. Macrovascular complications. Patients with diabetes are at an increased risk of cardiovascular diseases, including coronary artery disease, stroke, and peripheral vascular disease. Lifestyle modifications such as a healthy diet, regular exercise, and smoking cessation are essential. Statin therapy may be indicated for dyslipidemia management. Preventive measures: glycemic control. Mr. Rodriguez should aim for an HbAC target of less than 7%, tailored to his individual circumstances. Lifestyle modifications, dietary changes, G. Low glycemic index foods, reduced saturated fat, regular physical activity, and weight management are vital. Regular monitoring, regular follow-ups for blood glucose levels, HbAC, and screenings for complications. Educating Mr. Rodriguez on these points will empower him to take control of his diabetes and reduce the risk of complications. A 30-year-old woman presents with joint pain, a malar rash, and laboratory findings of positive anti-nuclear antibodies on an anti-double-stranded DNA antibodies. Discuss the classification criteria for systemic lupus erythematosus and the implications for treatment. Answer: the classification of SLE is based on the American College of Rheumatology ACA criteria, which include malar rash, a butterfly-shaped rash across the cheeks and nose, discoid rash, raised red patches that may scar, photosensitivity, skin rash as a result of unusual reaction to sunlight, oral ulcers, painful sores in the mouth or nose, arthritis, involvement of two or more peripheral joints with tenderness, swelling or effusion, serositis, pruritus or pericarditis, renal disorder, proteinuria or cellular casts, neurologic disorder, seizures or psychosis, hematologic disorder, hemolytic anemia, leukopenia or thrombocytopenia, immunologic disorder, positive anti-DNA or anti-Smith antibodies, ANA positive, a positive ANA test. To classify it as having SLE, the patient must meet at least 4 of these criteria, either simultaneously or sequentially. Treatment implications. Management of SLE is multifaceted and depends on disease severity and organ involvement. Mild disease, non-steroidal, anti-inflammatory drugs, NSAIDs or hydroxychloroquine for skin and joint symptoms. Moderate to severe disease, corticosteroids, e.g. prednisone may be necessary, along with immunosuppressive agents, e.g. azathioprine, mycophenolate mofetil, or cyclophosphamide for more severe manifestations affecting vital organs. Regular monitoring, continuous assessment for disease activity and potential side effects of treatment is critical. This structured approach enables effective management of SLE and minimizes morbidity associated with the disease. 50-year-old male presents with easy bruising and petechiae. Laboratory tests reveal a platelet count of 45,000 IL. Discuss the differential diagnosis of thrombocytopenia and the initial workup to determine the underlying cause. Answer: thrombocytopenia can result from decreased platelet production, increased destruction, or sequestration. The differential diagnosis includes decreased production, bone marrow disorders, e.g. aplastic anemia, leukemia, nutritional deficiencies, e.g. vitamin B or folate deficiency, alcoholism or liver disease, increased destruction, immune thrombocytopenic purpura, thrombotic thrombocytopenic purpura, TTP, disseminated intravascular coagulation, DIC, drug-induced thrombocytopenia, sequestration, splenomegaly due to liver disease or malignancy. Initial workup, complete blood count CBC to confirm thrombocytopenia and evaluate for other cytopenias. Peripheral blood smear to assess platelet morphology and check for associated blood disorders, e.g. leukemic blasts. Bone marrow biopsy if primary bone marrow disorders are suspected. Coagulation studies, PT and AP to evaluate for DIC. Autoantibody testing, antiplatelet antibodies if ITP is suspected. This comprehensive workup helps narrow down the diagnosis and guide further management of the underlying cause of thrombocytopenia. A 40-year-old woman presents with jaundice, fatigue, and elevated liver enzymes ALT 1500 or AST 1200 or hepatitis A, B, and C serologies are ordered. Discuss the significance of serological markers in hepatitis infections and the implications for treatment based on the results. Answer: serological markers are crucial for diagnosing and managing hepatitis infections. Key markers include hepatitis have anti-HAVIM, indicates acute infection. Presence suggests recent infection, usually self-limiting. Anti-HAVIG indicates past infection or vaccination. Hepatitis B, HB, HB-SAG, presence indicates active infection. Anti-HBs indicates recovery and immunity. Anti-HBCM indicates acute infection. IG indicates past infection. HBV DNA, quantitative measure of viral load. Hepatitis C, HCV, and THCV indicates exposure, does not differentiate between acute and chronic infection. HCV RNA confirms active infection and assesses viral load. In this scenario, if HB-SAG is positive and anti-HBs is negative, the patient has active HBV infection requiring antiviral treatment, e.g. tenofovir or entecavir if indicated based on viral load and liver function tests. If an TESHV is positive, HCV-RNA testing is needed to determine the active status and treatment options, e.g., direct-acting antivirals. Understanding these serological markers helps tailor treatment and monitor disease progression effectively. A 70-year-old man with a history of hypertension and diabetes presents to the emergency department with a sudden decrease in urine output and elevated serum creatinine, 3.5 mdl. Discuss the causes of acute kidney injury, and the initial steps in management. Answer: acute kidney injury can be classified into three categories based on the underlying etiology. Prerenal due to inadequate perfusion to the kidneys, often caused by dehydration, heart failure, or renal artery stenosis, characterized by low urine sodium, phoemecal and fractional excretion of sodium. FeNO is often 1%. Postrenal caused by obstruction in the urinary tract leading to back pressure in the kidneys. Common causes include kidney stones, enlarged prostate, or tumors. Initial management steps: fluid resuscitation. If prerenal causes are suspected, intravenous fluids should be administered to restore renal perfusion. Monitoring: regularly check renal function, creatinine, electrolytes, and urine output. Avoid nephrotoxins. Discontinue any nephrotoxic medications, e.g., NSAIDs, certain antibiotics. Further evaluation: if no improvement is seen, further evaluation through imaging, e.g., renal ultrasound or renal biopsy, may be warranted to identify intrinsic causes. This approach helps to differentiate the etiology of AKI and initiate appropriate treatment to prevent further renal damage. A 48-year-old man presents with sudden onset of severe pain and swelling in his right big toe. Joint aspiration reveals needle-shaped monosodium urate crystals. Discuss the management options for acute gout attacks and the long-term strategies to prevent future episodes. Answer: management of gout consists of acute treatment for attacks and long-term prevention strategies. Acute attack management. NSAIDs, indomethacin or naproxen, are commonly used to alleviate pain and inflammation. Colchicine, an alternative for patients unable to take NSAIDs, effective if administered early in the attack. Corticosteroids can be administered orally or as an intra-articular injection if NSAIDs or colchicine are contraindicated. Long-term prevention: lifestyle modifications, encourage weight loss, dietary changes, reducing purine intake from red meat and shellfish, and limiting alcohol consumption. Urate-lowering therapy. In patients with recurrent attacks or tophi, medications such as allopurinol or febuxostat may be initiated to maintain serum uric acid levels below some DDL. Monitoring: regular follow-up to assess uric acid levels and adjust therapy as needed. A 55-year-old woman presents with epigastric pain that improves with eating but recurs a few hours after meals. Endoscopy reveals a duodenal ulcer. Discuss the pathophysiology of peptic ulcer disease and the role of Helicobacter pylori in its development. Answer: peptic ulcer disease is primarily caused by an imbalance between gastric mucosal defenses and damaging factors. The key components include Helicobacter pylori H. pylori, a gram-negative bacterium that colonizes the gastric epithelium. It is a major risk factor for the development of both gastric and duodenal ulcers. H. pylori induces chronic inflammation, chronic gastritis, and disrupts the gastric mucosal barrier, leading to ulcer formation. Acid secretion: excessive secretion of gastric acid can overwhelm the protective mucosal barrier, contributing to ulcer development. Conditions such as Zolling-Gurlison syndrome may lead to increased acid production. Other risk factors: non-steroidal anti-inflammatory drugs, NSAIDs, smoking, and excessive alcohol consumption also play a significant role in ulcer formation by impairing mucosal defenses and promoting inflammation. Management. Treatment typically involves eradication therapy, a combination of proton pump inhibitors, PPIs, and antibiotics, e.g., amoxicillin and clarithromycin, to eliminate H. pylori, PPIs to reduce gastric acid secretion, promoting ulcer healing and preventing recurrence. Understanding the underlying pathophysiology and the role of H. pylori is crucial for effective management and prevention of peptic ulcer disease. A 60-year-old man presents with fatigue, constipation, and abdominal pain. Laboratory tests show serum calcium of 12.5 mdl and elevated parathyroid hormone (PEH) levels. Discuss the differential diagnosis for hypocalcemia and the management options based on the underlying cause. Answer: hypocalcemia can arise from various causes, primarily classified into 4 categories. Primary hyperparathyroidism, commonly caused by a parathyroid adenoma, leading to elevated PTH and calcium levels. Symptoms include stones, bones, groans, and psychiatric overtones or malignancy. Certain cancers, e.g., breast lung, can cause hypercalcemia via osteolytic metastasis or paraneoplastic syndromes, typically leading to elevated calcium with suppressed PTH levels. Vitamin D disorders, excessive intake, or granulomatous diseases, e.g., sarcoidosis, can cause elevated calcium levels due to increased intestinal absorption and mobilization from bones. Thyrotoxicosis, elevated thyroid hormone levels can increase bone resorption, leading to hypercalcemia. Management is tailored to the underlying cause. Hydration and diuretics. Intravenous fluids can help dilute serum calcium levels, and loop diuretics, e.g., furosemide, can promote renal calcium excretion. Bisphosphonates. If malignancy is the cause, bisphosphonates, e.g., zoldronic acid, can be effective in reducing calcium levels. Surgery. For primary hyperparathyroidism, parathyroidectomy may be necessary to remove the adenoma. Understanding the differential diagnosis is essential for directing appropriate treatment and preventing complications associated with hypercalcemia.